This is Blood and Cancer, the official podcast of MDedge Hematology Oncology. I am the voice of MDedge Podcasts, Nick Andrews. And welcome to episode 79 of Blood and Cancer, the official podcast of MDedge Hematology Oncology. I am the voice of MDedge Podcasts, Nick Andrews, and Dr. David Henry is not here with me this week. He's enjoying a much-earned vacation somewhere down the Jersey Shore, as we like to say in our neck of the woods. He and I, of course, both reside in Philadelphia. This episode, we have Dr. Don Dizon, and this is sort of I think this is a good time for this. It's a reflective piece on COVID-19. It's a diary of an oncologist, and he's going to talk about how it impacts him personally, how it impacts his patients, other professional aspects of being a physician in the time of COVID-19, and specifically the patient information, very, very helpful as well. So it's going to be a great interview, and as you know, certain states open back up and there are spikes in cases, I think this might be a really poignant time. We wanted to release this when there was enough time to reflect on what the pandemic has done for all of us. So that interview is coming up shortly. We'll get right to that interview pretty quickly. Remember, we love 5-star reviews on Apple Podcasts or iTunes. We read all of those. We take them seriously. We really appreciate if you feel like we're doing a 5-star job. You want to write a review or ask a question or interact with Dr. Henry or myself, you can do it on Apple Podcasts and iTunes, or you can do it in our email at podcasts@mdedge.com, and you can interact with us on Twitter at MDedge. Onc. Okay, so let's just get right to the interview. Please welcome Dr. David Henry and Dr. Don Dizon.
I'm your host, Dr. David Henry, and you're listening to Blood and Cancer podcast, which airs every Thursday morning on iTunes or wherever you get your podcasts from. And today I'm delighted to be talking with Dr. Don Dizon, who is a practicing medical oncologist and director of women's cancer at Lifespan Cancer Institute, Providence, Rhode Island. And Don, thanks very much for taking the time to talk to us today.
Happy to be here. Thanks.
Well, I'm intrigued as we get to our interview, hearing that you took the time, as all of us started, we're recording this toward the end of May in 2020, and maybe a lot of the country has peaked, although some are not quite sure, and we're all used to what's happening, but you took the time to keep a diary as a practicing medical hematologist oncologist on what was happening. So can you tell us what you did, and maybe some entries were, I think we're going to cover inpatient, outpatient, teaching, research, and family life. What was it like as you started to keep your diary?
Yeah, it was actually a very interesting opportunity that was presented. I'm a columnist for Medscape, and when COVID-19 happened, they approached me to see if I would be interested in just sort of creating a journal of what it is like and how things are and how things may change as COVID-19 entered New England. And I started around the time when things got very hectic in New York City, and that's when a lot of the planning in Rhode Island was just really starting to take off in earnest. And there was certainly a sense that things were changing for me, just trying to manage the cancer center and a clinic that I certainly had, but also administrative responsibilities of how to cover the floors, because at this point we learned that residents were being pulled off the inpatient service in oncology, and we were basically left to our own devices to figure out how we were going to take care of our inpatient services. And
so your residents were pulled from you. I know our medical students had to disappear, but your residents were pulled from your service.
That's right. They were pulled to cover the ICUs.
Right.
And cover the floors that were being quickly converted to care specifically for patients with COVID-19. And when you couple that with what was going on in the state, which included closure, a lot of daycare facilities in both Massachusetts as well as Rhode Island and Southern Connecticut, that presents a problem for working families, especially our young faculty, who all of a sudden had kids out of school and did not have the daycare capabilities, and how to juggle all of these real familial concerns as well as societal concerns, and also ensure patients were getting treated and seen as expeditiously as possible, all was circling around in everyone's head, and I just had the opportunity to sort of write out my thoughts as it sort of progressed over 2 weeks.
Well, how did some of your entries look, or you recall, in the beginning, and maybe then a few weeks in and a few more weeks in? I guess we're like 9. Our medical students were suddenly pulled on a Friday, second week of March, so that's March, April, and May, so 2.5 months.
Yeah, it went, looking back at these entries that I created, it went from a lot of anticipatory fear and anxiety about how things would change to, especially not only around just service, but also for our patients. It was a time when, masks came into use in the clinic. It's a time when, visitation policies were getting restricted. First it was one visitor only, and then it was no visitors at all. And just worry about not only mental health for faculty and myself, as I worried about whether or not I was going to take the virus home to my family. But it was also just worrying about the quality of life for patients who are coming into the center who are used to coming in with family and have to now come into the center either just for a visit or for prolonged infusions by themselves. So then it became more of this reality hitting and what that looked like. And one of the columns I remember vividly writing was around being the inpatient attending for a week in the hospital. And one of my jobs was specifically to see patients with cancer who were also infected with COVID-19. And that was just a very, very sobering experience. I found it exceptionally difficult, even now, to, when you add the aspect of having to gown and glove to that degree and then walk onto a ward there was absolutely no one else on that floor except for healthcare workers, essential workers, and patients. There was no laughter, there was no levity, and it was exceptionally lonely. That's what I took the most about that experience. And then now coming into this, it's sort of the wonder of what things look like now. I don't want to look at a world of healthcare where telehealth is how we're all seeing patients. I think there's something exceptionally lacking in that.
Well, the image I'm getting, and you make such a good point, I've seen and think also you walk on the floor where there was a hustle and bustle and there's not. You have a cancer patient, maybe COVID positive, maybe a little sick, who is alone. You're all gowned and gloved, so what could be worse and more lonely than in a room by yourself? The person walking in is hard to even recognize and is talking to you about two potentially bad or fatal illnesses, and then you have to leave.
Right.
So I've been thinking about the patient, but you're thinking about the caregivers and the effect. We're all human and we're wired differently. Have you seen in yourself or colleagues where this is very stressful?
Yeah, no, it's been exceptionally taxing. I think I like to get to know my patients. I like to put a hand on the shoulder if it's appropriate, and I like to give the patients I've been taking care of for years a hug when they leave my office. And to have that physical contact removed from routine care has been jarring. Let me put it that way.
Yeah. Now, what did you or have you seen? So no interaction. In fact, your residents were pulled, and medical students. How has teaching been, both to trainees or to your colleagues, staying up to date with teaching?
Right. I think teaching has taken a severe beating in that regard. So when our residents got pulled, our fellows were pulled out of the outpatient clinics. And as you know, oncology and hematology is really an outpatient specialty. That's where you learn much of the field. And these fellows are being pulled to do residents' work, taking care of inpatients. And so they're seeing acute oncology, which maybe is 10% of everything they need to know. We tried very hard to continue a fellows tumor conference on Fridays, but we're missing them, and we're worried about their education because they're not in our clinics. They don't see outpatients at this point. And for the residents, I think there's something that's going to be damaging if they are in intensive care units for as long as they might have to be, because even though the surge has sort of subsided, the level of intensive care for patients who do get sick with COVID seems to be stable, but we're not down to just one ICU yet even.
Yeah. Same thing here. The surge and high death rate and almost chaotic care to just take care of this patient, that patient, and almost burnout of the patients and the health caregivers has dialed down to a steady state of similar. So it's a little easier, less taxing, but still no taxing. We've gone to, for the house staff, 1 week on, 1 week off, and so they're out of here. Again, the whole focus, like in your office, like ours, we have no social workers on the floor. We have no research coordinators on the floor. The billers are not they're all gone. Dietitians, your entire cancer support team is gone. It's lonely in the office, actually. And everybody's social distancing in the waiting room, and nobody can come back with the patient. So, it's this new normal now, as we kind of enter a yellow phase, I guess, which will be for a while, is also lonely. What happened with research? Did research stop?
Well, so that didn't stop. I think we made a concerted effort to maintain as normal operations as possible in the research program as well. So my clinical trials continued. I worked, one of the things I did discuss was the importance of continuing research, but not at the expense of patient safety. And I'm running a clinical trial for a very rare tumor type called clear cell cancer, and it's an immunotherapy trial, and it's sponsored by a pharma company. And I had patients traveling in from Providence by airport. I mean, they were coming in from the south and as far as from Canada at some point. And the FDA did provide guidance on how to continue clinical trials during the pandemic, and we took that to heart. And it took a lot of time, but I was able to keep a patient on clinical trial and yet not require them to come to site for treatment. And essentially, I was able to get investigational product to the patient where she lives, and because traveling today, it wasn't safe and still isn't.
Now, were your coordinators in or working from home? I guess you have some nursing or scientific help for your research in the office at the same time?
Yeah, I think it's just like yours. It's a significantly scaled down. We have a person who's coming in the office Monday through Friday. Everyone else is working remotely.
And then how about, do you have family and young children?
Yes, I have 3 kids.
So how did that work? And did you do some telehealth at home and kids bouncing around? And how did that work to try and continue your specialty at home?
Well, I think the hardest part was so my oldest daughter is a senior in high school.
Oh, yes,
and I think the trauma of this experience on her has probably been the greatest, just to see all of these things that you look forward to as you graduate high school taken away from her because of a health emergency. It's been very difficult for her to accept, and I think she struggled like many other people her age. My other 2 are in middle school, and they have a very active social life via the computer.
Sure.
And, so my daughter Skypes with her friends, and my son plays video games with his friends, and they're very content. And they've actually taken to learning on the computer pretty well. And they're okay. I mean, I think they would prefer to be able to see their friends in public, but so far so good.
And how about your daughter's graduation? How did they handle it? You've seen probably on TV various ways of handling this, either entirely electronic or one person walks across the stage at one time. Any way their high school handled it?
Yeah, I think it's going to be one person walking in front of the stage at one time without an audience. I think it's going to be at the local public network station, but it's just not. It's not what it should have been.
No, it's
for sure.
It's almost too sad. And in Providence, here we are, end of May. Are you seeing up, down? Sounds like about the same level as steady. And any clinical trials or thinking toward more testing and antibody testing in Philadelphia is starting to surge. We have 3 major universities, Temple, Jefferson, Penn, and across the river, Cooper, are all trying to get involved either with vaccine or checking antibody to see who's positive, who's negative, and whom might have conferred immunity.
Yeah, we're doing much of that work as well. I think we're trying to, Rhode Island is one of the better states in terms of testing in the nation, so that's been great to see. I think for the Cancer Center, we're just trying to figure out how to operationalize this as society starts to open up it once more, and trying to figure out how to test and allow patients and visitors back into the institution is a big issue. We don't have the amount of tests necessary to allow for it yet. And then I think more important than the testing is what are the consequences of testing. So, we had a very long discussion about testing all patients coming into the infusion unit, but the question then becomes, if someone's asymptomatic and tests COVID positive, are you really going to quarantine them and not give them their chemotherapy? And what if it's in the curative setting? Are you really going to delay them for 2 weeks? And I think there's just a lot of unknowns about that, and we're trying to go where the science points us and trying to find out what to do, just like a lot of other hospitals are.
And we've wrestled with the same thing. We've learned recently that you can test positive for a while because some of the protein of the virus is still in your nasopharynx, but the virus is dead. And so I have a patient waiting 8 weeks to get his therapy again with an immunoantibody because he keeps testing positive. Of course, they won't let him in the door, but he's probably not contagious by all these evolving data.
I had the same scenario with a woman who has HER2 positive disease and was COVID infected 8 months ago, and she's still positive.
Yeah,
and she's asymptomatic.
Yeah, and so of course, there's a number of tests all across the country popping up to address this, and we just have to wait for the ones that come through and are vetted. So you mentioned in the beginning, so you're a writer for Medscape, but want to be sure and recognize that. So tell us what you do and how often on Medscape so we can look for it.
So I write on thoughts about medicine as an oncologist, but my columns tend to, for Medscape at least, I try to find topics that are relevant for all of us and not just oncologists. That's been the next challenge about this. And I sort of carried that out when I did the COVID-19 diaries for them as well.
So those are columns from time to time on Medscape now under your name?
Yes.
Okay. Well, anything else you wanted to mention? Very interesting talking to you and hearing about what one practicing medical oncologist decided to do and keep track of the inpatient, outpatient teaching, research, and the family. When do you sleep? Are you sleeping okay? I sleep like a baby every night.
I am not sleeping okay. I think that's one of the things about this pandemic. I typically will wake up at anywhere between 5 and 5:30 every morning, but it'll be this slow awakening thing. But since this pandemic, I've been up and I've been awake now at 5 and 5:30. It's been unsettling.
Yeah, and you add to that, many of us are lucky enough to be still working and still being able to support families, and many millions are not, and you can only imagine the extra anxiety there. Well,
absolutely.
Don, I can't thank you enough for taking the time to talk to us today on the Blood and Cancer about what's happening to a medical oncologist in various aspects of his life, which are being chronicled on Medscape if some of our listeners want to read in and listen in to you. And again, to remind everyone, we've been talking with Dr. Don Dizon, who is a medical oncologist, director of women's cancer at the Lifespan Cancer Institute in Providence, Rhode Island. And you can find us on mdedge.com/hematology-oncology. And it's the podcast entitled Blood and Cancer, airing every Thursday morning. And we all thank you very much for listening, Don. Thanks for joining us today.
Thank you so much for the opportunity. This was great. Thank you.
You're welcome.
And that concludes episode 79 of Blood and Cancer. Blood and Cancer is produced by MDedge editor Jennifer Smith. It's hosted by the editor-in-chief of MDedge Hematology Oncology, Dr. David Henry. All MDedge podcasts are produced by the Vice President of Medscape, Dr. Ivan Aransky, as well as MDedge Executive Editor Kathy Skarbeck and MDedge Multimedia Editor Terry Rudd. Our social media presence is produced and coordinated by Kyla Clark. I am the voice of MDedge Podcasts, Nick Andrews. You're listening to Blood and Cancer.